but he moved to the Nagoya University as a head of diagnostic and interventional radiology. Congratulations.
Thank you very much. Thank you, Chairman, and good morning, everyone. I'm MASANORI INOUE from Nagoya University, Tokyo, Japan. So it's my great honor to be here to make a presentation. Today my topic is the indication and treatment of visceral artery aneurysms. I have nothing to disclose with respect to this presentation. So first, I'd like to start with the general issue about the visceral artery aneurysm. Then I will go to the indication of the treatment and treatment strategy. Finally, I'll show you some cases of visceral artery aneurysms. So the visceral artery aneurysm is a rare disorder with a high mortality rate in the event of rupture. And there is a growing trend toward endovascular treatment because of the high efficacy and low invasiveness compared to surgery. And also the treatment indication for the visceral artery aneurysm depends on the location of the aneurysms. And as for the treatment of wide-neck aneurysm with the patient where all branches is more complex and may require experience and advanced technique, including the neurointervention. So about the etiology in general, atherosclerosis is reported to be the main cause of visceral artery aneurysm. However, of course, there are many etiologies: arthritis, infection, traumatic, and arterial dysplasia, including the fibrovascular dysplasia, Ehlers-Danlos syndrome, and Alpha syndrome, and so on. And also the median artery ligament syndrome is a very important reason of the visceral artery aneurysm. Because due to the median artery ligament syndrome, celiac axis is obliterate or sometimes there is a very severe stenosis. Finally, as a result, there are pancreatic artery aneurysm develop. So the incidence of the visceral artery aneurysm is reported to 0.1 or 10% between 0.1 and 10%. And most are the asymptomatic. And the splenic artery aneurysm is the most frequent one, followed by the hepatic, renal, and gastroduodenal artery aneurysms. And this is the overview of the currently accepted indication of the treatment of the visceral artery aneurysms. For example, the renal and splenic, the size is more than 2 centimeter or 3 centimeter, 3 centimeter, depending on the papers. And of course, the size is including all aneurysms should be treated. And also the renal or splenic female gender within the childbearing age is the indication. And also among them, the other important point is the pancreatic artery aneurysm. This kind of aneurysm should be treated regardless of the size. So I'd like to talk a little more about the renal and pancreatic artery aneurysm. But first, I'll show you the recent clinical practice guidelines. Based on the from the European Journal of Vascular Surgery and the Journal of Surgery, this is the recent clinical practice guidelines. And in the most location, the evidence level is not so high, C or grade. But in the pancreatic artery aneurysm, the evidence level is A. So before you treat the manual, you must know that these are clinical guidelines. So first I'd like to focus on the renal artery aneurysms. So previously the size criteria is more than 2 centimeters. However, more recently, there was two very famous papers from the Journal of Vascular Surgery. In both papers, the authors follow up the renal artery aneurysms, and both authors concluded that the growth rate of the renal artery aneurysm is very slow 0.6 millimeter per year. And also the risk of the rupture is very low of the renal artery aneurysms. So the most authors concluded that the recent guideline recommendation is too aggressive. So however, one of the older recommended us 3 centimeter of the renal artery aneurysm should be treated. However, really true. Of course, there are some reports of the rupture of the renal artery aneurysm. The size is less than 2 centimeter. In this case, spontaneously the renal artery aneurysm rupture without trauma. So, of course, I think there is a room for discussion about the implication of the treatment of renal artery aneurysms. And also, if the size was 3 centimeter intravascular treatment, that means the side parking of the aneurysm is very difficult. Also, we need out of coils. So, from my clinical experience, usually I treat the renal artery aneurysm more than 2 centimeter. But of course, there's a room for discussion. So this is the case of the huge renal artery aneurysm. The size is about 3 centimeter. If we treat the renal artery aneurysms, of course the risk of the rupture is very low. So I think we must preserve whole branches to preserve the renal function. So in this case, I use the neurostent and the stent techniques and avoid the renal artery aneurysm like this. Also, you can see that the whole branch are preserved. However, it's very expensive treatment. So next, I'd like to talk about pancreatic dural artery aneurysm. The most important point is that we must treat this aneurysm regardless of the size, because the size is not the determining factor of the rupture. If the size is very small, in this location, the aneurysm easily rupture. So we must treat this aneurysm regardless of the size. And of course, other than the renal artery aneurysm, in this aneurysm, front and back bone embolization is preferred because there is almost no risk of the organ ischemia if we embolize the carotid artery. So these are the treatment strategies. Of course, the embolization include the front and back bone embolization and parking. Also, the stent graft is also a good option for some kind of visceral artery aneurysm. And surgery and hybrid surgery is also one of the options. Front door and back door embolization is very technically easy and also less invasive. However, the disadvantage is that this embolization is sacrifice the organ flow. And on the other hand, side parking is technically very difficult. However, the side parking can preserve the organ flow is a big advantage. So that when we do the renal artery aneurysm, of course, usually I use side parking. Maybe in most countries, the stent graft is also not can be reimbursed by the government or the health insurance system. It's a big problem. And after we put the stent graft, of course, the patient must take the dual antibiotic therapy. It's another disadvantage, I think. So first I show you the front door and back door embolization. This is a case of the rupture of the pancreatic dural artery aneurysm. So you can see that the size of the aneurysm is very small. However, this location, the aneurysm is easily ruptured. So you can see the very fine aneurysm in the inferior pancreatic dural artery. So I selected this artery and performed the front door and back door embolization. So the aneurysm disappeared quickly. So in this location, the front door and back door embolization is the most preferred because there is no risk of organ ischemia. And of course, we can do it by the side parking. high. So in that meaning, from one visualization is preferred, in my opinion. So how about these aneurysms? In this case, in the celiac artery is occluded due to the median artery ligament syndrome. So there is a multiple aneurysm in the pancreatic artery. In this case, if we avoid all aneurysms, I think that there's no flow from the SMA to the celiac region. So if we avoid these all aneurysms, I think there's a risk of the organ ischemia, that is the liver ischemia. So in this case, we plan to perform the frontal visualization and bypass surgery. So you can generalize for aneurysms in these locations. So we advise all aneurysm frontal visualization. However, you can see that the SMA angiography shows that there is no flow from the SMA to the celiac region. And also the celiac axis is occluded. So that simultaneously we perform the bypass surgery from the iliac region to the hepatic region by the vascular surgeon. Nothing happened. So it's very rare case, but sometimes we need a highly treated. So another very interesting topic is the ligament resection of the median artery ligament syndrome. Of course, if there is an aneurysm in the pancreatic duodenal artery, embolization is the first option. But some others insist that there is an option for the ligament resection of the median artery ligament syndrome, because the ligament resection can normalize the blood flow from the celiac to the liver. So this is a very interesting paper. You can see the celiac axis severe stenosis, and also you can see the small aneurysm in the pancreatic artery. However, after the resection of the ligament, the blood flow is normalized, and there is no aneurysm. So of course, there's a room for the consolidation of the ligament resection. However, of course, the ligament resection is either invasive, and also that we can control the aneurysm by the embolization. So, but maybe there's a room for discussion. Then I move on to some marking. Of course, this is the basic 3 steps: framing and filling and finishing. It's a neurointervention technique. However, in the abdominal region, in most of the cases, the size of the aneurysm is very large, and also the neck is very wide. So we need these kind of adjunctive techniques to preserve the parent artery, balloon assist technique, stent assist technique, and double or triple microcast techniques. In the clinical station, usually we use this kind of reverse type guiding seats to calibrate the target artery. And then we put 2 guiding seats. From 1 guiding seats, we put the balloon for the necroplasty. Then we put another guiding seat and insert the 2 microcatheter into the aneurysm and embolize. Also, the working angle is very important. During the procedure, in the barrel view in the perpendicular to the parietal artery, the right suture. In this barrel view, you can separate the aneurysm and parietal artery completely. So it's very useful view during the embolization. This is the wide renal artery aneurysms. In this case, I put the balloon across the neck. And this is a complete barrel view. You can see the balloon tangentially. Then I put 2 microcatheter in the aneurysm. First, I put 1 coil. However, the coil is moving in the aneurysm. It's unstable. So before we touch this coil, we insert another microcoils from the other microcatheter. Now the 2 coils embrace each other and make a good frame. And in the frontal view, we are sure we can preserve the parent artery. However, in the right side, you can see that In the body view, we are sure we can preserve the current artery, so the working angle is very important. It's a final angiography, and it is completely embraced, and also we will preserve the whole branches. However, this aneurysm is a very big, large inner aneurysm. Also, there is also no neck, wide neck. So in this kind of case, we must use the stent to preserve the current artery. So in this case, first I put the stent from the main trunk of the inner artery to the branch. It's a neural stent, Elvis from the microtension, and then we put the main coils inside the aneurysm. It's a final result. Finally, I show you the stent grafting case. What do you think about this case? This is a young man, and there is a huge aneurysm in the main trunk of the right inner artery. Also, the neck is so wide. So first, this patient went to another hospital, not in my university, another hospital. And at that hospital, the radiologist tried to perform the stent assisted coiling. So they put the smart stent across the neck. However, the stent migrated a little to the distal portion. And what happened? Proximal stent was migrated into the aneurysm. So they stopped the treatment. This is the CT scan. It's very dangerous because the proximal stent is protruding to the artery. So it's a very high risk of rupture. After that, this patient came to my university. And also you can see that there is a stenosis at the posterior of the renal artery. So how to treat this patient? So my plan is to put the stent graft, advance the stent graft through the stent strut, previous stent strut to the distal portion, and put the stent graft like this. This is our strategy. And I selected the VDX stent graft. So finally, we can advance the catheter through the stent strut to the distal portion of the renal artery. And perform the IVAS, check the root of the system. This is the previous stent. Then we advance the VDX stent graft and inflate balloon. The stent graft completely cover the posterior of the aneurysm. This is the angiography. Very beautifully stent graft was placed, and completely the aneurysm disappeared. And also we treated the stenosis of the renal artery simultaneously, like this. It's a very beautiful result. So now I will overview the current issue with visceral artery aneurysms. So the management should be based on the location of the visceral artery aneurysms, and the recent advances in the vascular treatment have resulted in the increasing IR as an alternative to the open surgery. Thank you for your attention.